this is going to be a bit of a different lecture from the usual lectures you used to have here. This is more relevant, I feel, to medical professionals as well as the hospital staff. This is about silent struggle in white coats and navigating mental health, enhancing resilience, and how to enhance our resilience and the learning from the tragedy we had. Frequently hear stories about tragedies among our colleagues. Right? These are from paper articles and the web, and probably some of the stories familiar to you. In one incident from Tambuttegama, one incident from Vellabaya and Karapitiya, all were suicides. Well, if we dig into details of these cases, and now we are saying it's cases, but these are colleagues, and some of the I have taken some screenshots from their Facebook websites. They few weeks before this unfortunate events, and they have put some Facebook messages. It says, and you can read, I suppose. And it shows and how they were desperately fed up with the things happening in their life, and the one message, and that they were feeling like it's more of a suicidal notes. This is one of the story, and the Dr. X, and he's 40 years old, and was having challenging life marked by personal and professional struggles. And when we go into his family life, his father left him at the age of 6 years, and he was struggling. He's the only child, and mother was a single parent and was struggling throughout their undergraduate life, and has taken treatment, not have taken treatment, but he has been struggling, faced various problems, and following how some of the other, he managed to finish the medical career, and became a doctor, and he got married and had 2 children, and then the pressure was mounting, and balancing family life, workload, and he had frequent conflict within the family, and he was struggling with financially, and to seek a help, and he turned towards alcohol, and gradually he developed alcohol dependence, and the increasing use of alcohol made a lot of problems in that workplace, in the family, and frequent conflict with colleagues, and he had anger management issues, and he at the end, and he couldn't cope with the stressors that he had, and he became overwhelmed, and unfortunately he committed suicide. This is a story. Not I have changed some of the things, but the name and the age, and the story is more or less relevant to the incident we heard recently in Anuradhapura area, and where we did go wrong, and what we see in the suicide and the suicide related behavior. Those are the tip of the iceberg, and a lot of things beneath that, and we need to address, and rather than help, and we need to help suicide related behaviors also, but there are a lot to address beneath the sea level. With that story in mind, and our objective of this presentation today, understand the prevalence and the impact of mental health issues among medical professionals, identify key risk factors and warning signs for the burnout, depression, and substance use disorders, and explore strategies for enhancing resilience and promoting supportive work environment, addressing stigma, and encourage open dialogues implementing effective intervention for support programs. This is our objective, this presentation. What is mental health? And this is mental health is a state of mental well-being that allows individual to handle life stresses, realize their potentials, and they learn and work effectively and contribute to their community. And it is not just absence of mental illness. And it's very important part in health. And we used to focus mainly on physical health, isn't it? And but physical health is important, very important. But similarly, the mental health, if somebody doesn't have good mental health, and it doesn't matter whether they have good physical health. And it's very important to realize the importance of mental health in our practice and in ourselves, right? We are most of the time looking at treating patients, and we were trained, and it's not your fault, and you were trained in a way that you are thinking in physical disorders, right? Okay. If you go into a little bit of epidemiology, this is one of the Sri Lankan study recently published, 2023, and they have done the screening, and where they found 11.2% of depressive symptoms among PGIM trainees, and 8.9 had anxiety symptoms, and 1.9 had high level of stress. This is, mind you, this is Sri Lankan study done in PGIM trainees in Sri Lanka. And you see there's quite a significant number of candidates in PGIM having mental health related issues. And during the pandemic period, this study done aftermath of pandemic, the corona pandemic, that period, and it showed that there's an increase in depressive symptoms among healthcare professionals during that period. You can remember, some of you have been working in COVID centers and engaging with delivering service, and you might remember that how stressful was that period. That period, the depressive symptoms went up to 39% and had significant severe anxiety. Then why it's important? High level of emotional exhaustion among doctors and correlate with lower quality of care. And that when they are exhausted, and that they find it difficult to deliver good quality service to their clients. And there's one of the meta-analysis that meta-analysis showed that job demand negatively impact the emotional well-being and consequently patient care and quality. You're hearing a lot of from the media. You hear frequently that patients are complaining that doctors are not giving the proper care. Sometimes they're having problems, they are criticizing. Why is that? And you'll find answers in this lecture. Right. Negative attitudes towards the mental health issues among medical staff exacerbate the tension in doctor-patient relationship. Some, when they have negative attitudes towards the mental health, and they tend to have poor quality patient care. Right. These are the evidence and a little bit of evidence, and this is the impact of mental health problems and the burnout, high level of stress and exhaustion, and lead to reduced work performance and the job satisfaction. Emotional strain, that increased risk of anxiety, depression. and emotional detachment from the patients, and the physical health issues also. You can get physical health issues. Poor mental health can contribute to some features like fatigue, headache, and sleep disturbances, and professional performance at the end of the day. When when you're not sound in mental health, and that you might take wrong decisions, and they would be it might affect patient care and might affect you also. And work-life balance, and it's quite challenging to maintain healthy balance between uh, personal and professional lives, and there's a lot of stigma associated with that, and see, that's to seek help due to fear, and they might feel that other people might judge you, and mm, then there may be a career repercussion, and that's a lot of stigma. You might know that a lot of stigma in mental health is seen among health professionals, not um, more than the community. That's, you can see, when you want to give a punishment transfer, and then you will be selecting the administrators would select mental health ward, and if that the punishment transfers goes to mental health, and that's how the stigma is. And there will be problems in relationships, and they were not doing, there have been there might be problems in teamwork as well. All right. Let's talk about a little bit about stress. Right. What do you know about stress? Stress is psychological stress is mental or emotional strain that result from challenging or adverse situation. It occurs when individuals perceive that they do not have the resources to effectively cope with demands placed upon them. Because stress is everywhere. Every person, if they are alive and they have stress, only the dead people does not have stress. Is it always bad? That we need to sort that out. Right. There are two types of stresses. One is acute stress, one is chronic stress. Acute stress is short-term stress that can be beneficial sometimes. And it helps people to respond quickly to immediate challenges such as tight deadlines or sudden problems. Acute stress can improve the focus and the performance in short term, motivating individuals to overcome obstacles and solving problems. The chronic stress is a long-term stress that persists over time and can have negative effect on their health and well-being. Chronic stress can lead to physical health issues like cardiovascular problems, weakening of immune function, and mental health concerns such as anxiety, depression, disorders. This is well known. For instance, in acute stress, we can see in OPD setting. We can take our example from the OPD. You know, this Anuradhapura OPD in charge is here, and it's very busy. And let's say there are 10 medical officers to handle 700 odd people. In the OPD, one person has to see 70 patients within maybe 4 hours time. In an unfortunate event, then like some illness, diarrheal or respiratory illness, and spreading, and the 4 people got sick, right? 6 people have to cope with the demand, right? When you hear that story, and the rest of people who is going to the clinic will be stressed. That is acute stress, right? Then they know, and that they have to cater around more than a little bit more around more 100 patients. It's more than the usual, and that they have stress. And if they have good coping strategies in acute stress, they can have set of things to cope with that stress. They can do time, little bit of time management. They can do, uh, they can cut down some of the unnecessary, not unnecessary per se, but you can cut down some time from other areas and they utilize in the clinic, and they might come in the little bit early. And that's, in a way, they can cope with that stressor, but it's a stress, it's acute stress. Right. In a chronic stress setting and in the same OPD, let's say 5 people have decided to migrate and only 5 people left. There are no people, no medical officers to come from other areas, and so they will be stressed. And they know this is not going to solve in near future, and they will be overburdened, and that is chronic stress. They need going to that drag for several weeks, maybe months. Right. And that I told you that this stress is bad. Little bit of stress is good. Actually, if you don't have a stress, for instance, if you are facing an exam and you're pretty sure that you are, and there are no other candidates, and if they want to select, and you will get selected, and why are you bothering studying? That's pretty straightforward. And that there is no motivation. And if there's no stress, there won't be there won't be any motivation. But when the stress increases gradually and performance increases to a point where you can't cope with the stress. So with too much stress, and your performance is going to go down, and you get exhausted, and gradually you go into a phase of burnout. And later they can go into they might develop mental health disorders even. So it's important to understand the stress. In the stress, there is a perception of threat. Stress is often arise from when people perceive situation as threatening or well. This perception triggers a stress response, even if the actual threat is not imminent or tangible. Sometimes they might not have a tangible or sort of immediate sort of stressor, but still they can have the perception of threat. Right. For instance, if you hear that somebody, let's say in your team, and the consultant is coming and who is quite from the rumors you get, and he's very harsh, let's say, and you go into a phase of stress before he before he reporting the duty. Right, the unit get panic. That is perception of threat, even though there's no immediate or tangible threat. But perception per se can cause stress reaction. And there's a set of cognitive appraisal where the patient evaluates the situation, and that's play a crucial role. And if they see it is beyond their control and they has a significant challenge, and the stress level increases. And this colored with his past experiences, personality, that the coping strategies comes under personality. The past experience gives, they alters their cognitive appraisal. For instance, let's see, if somebody get blamed or traumatized in front of their colleagues by a consultant, next time when that consultant comes, and then that, like, hearing that also can trigger anxiety because of the cognitive appraisal of the situation. And there's an emotional response to the stress. And it's range from anxiety, frustration, anger, sadness. It depends on the personality. Some people are quite introverted and they have sadness and they have anxiety symptoms. And some are extroverted and they have frustration and they have anger, impulsivity that we can see. And the behavioral changes that we can see on psychological stresses can lead to behavioral changes like avoidance, procrastinating, and changes in social interactions, and they get isolated, and it might affect their decision making and problem solving abilities. And coping mechanism, there are two types of coping mechanisms. One is called adaptive coping mechanisms, and other one is maladaptive coping mechanisms. Adaptive coping mechanisms are problem solving techniques and the seeking support, time management, and cognitive restructuring, that sort of things comes under adaptive coping mechanisms. But the maladaptive ones are more of substance use. They might opt to substance use and avoid avoidance, and they can have problem with eating patterns and aggression. And some people nowadays, what we see is frequently they spend time on screens. Screen time go up. That's a recent development. And they might be in denial and they can have self-harm, and then some people are having compulsive spending and so on and so forth. And there are a lot of maladaptive coping strategies also. And then chronic and intense psychological stress can lead to mental health issues like anxiety disorders, depression, burnout, substance use disorders. And they can have cognitive symptoms like difficulty in concentration and memory. This we see in stress, right? And mind you that when we come to the personality of doctors, and they are very sort of they are new. Majority of the doctors, what I have seen, and in the documented also, they have more of a neurotic personality. They are having a lot of perfectionist traits, obsessional traits, and they are very sensitive and they find it difficult to cope most of the time. Most of the doctors doesn't have good coping skills also. Well, what are the signs and symptoms? And that's important to identify the stress. And they have persistent fatigue, and they feeling tired and exhausted, and they might come with headache and worsening of migraine, chest pain, aching, the palpitations, and shortness of breath. These are anxiety symptoms. And the disturbance in sleep, some people sleep insomnia, some people have excessive sleep, and weight changes, and digestive issues. They frequently come with stomach aches, nausea, diarrhea, that sort of illnesses, and anxiety. With the heightened anxiety, they can come with fear and panic, and they can have depersonalization symptoms like feeling detached from the real self. And they can have extreme mood swings. And some people can have impulse control problems, and then they behave than their usual self. Frequently, we see substance abuse and abuse of medicines, and that we frequently see among medical professionals and other substances also. When we go to burnout, what is burnout? Burnout is a state of emotional and mental and often physical exhaustion brought by prolonged or repeated stress. Generally, uh, it's work related. Sometimes it can happen among other stresses with other stresses like parenting, caring, romantic relationships. Most of the time, burnout, what we see in work environment, but you might get a child with frequent problems, conflict with parents, and they may be hyperactive, or they can have conduct symptoms and like they do a lot of socially unacceptable things. Then the parents get exhausted and they get burnout. And caretaking, especially elderly, dementing patient, when people are caring for dementia patients, they also get um, burnout. And romantic relationship, especially when the partner is having some borderline personality traits, and this we frequently see. Other one is getting traumatized and burnt out, and that's we see. But it's common thing is to say in the working environment. Right. What are the features? And emotional exhaustion, and they feel that they're drained, like they're overwhelmed, and that they emotionally depleted, and they have depersonalization symptoms develop. They cynical or detached attitudes towards work and with colleagues, and they get detached, and they reduce the sense of accomplishment, and they're experiencing feeling of ineffectiveness or lack of achievement. Physical symptoms, they can present with chronic fatigue, headache, gastrointestinal issues, as I told you before. And chronic impairment, we can see the difficulty in concentrating, forgetting frequently, and reduced problem-solving abilities. They get socially withdrawn from the family and friends and colleagues. And a little bit about depression. And the thing that when the people are burnt out, and if we don't address that issues, and if we can't continue cope, and if the stressor is continue to present, and they might go into depression, or the depression is a mental illness. Depression is persistent feeling of sadness, of lack of interest or pleasure most of the activities, and it characterized by range of emotional, cognitive, physical symptoms, and they cause significant distress and impairment of daily functioning. And that's the next stage that people might move, and that is the depression. In depression, we have this is ICD-11 new diagnostic criteria, and this would have some of the adapters when they are working with patients. Then they should have at least one of the affective cluster, that depressed mood of the most of the day, nearly every day, and the loss of interest and or pleasure most of the activities. We need to have one of these. These are called affective cluster, and it should present for most of the days for the last 2 weeks. And in addition, we call it cognitive, behavioral, and vegetative symptoms. And then out of that, we need to have at least 3. And significant weight loss or gaining weight or change in appetite, insomnia or hypersomnia, and psychomotor agitation or retardation, feeling fatigue or loss of energy, feeling worthless, excessive guilt, diminished ability to think or concentrate or indecisiveness, and recurrent thoughts of death and suicidal ideation. This would be, this is where we need to really think about. We need to prevent people moving to this stage. If they have gone into depression, we need to treat assertively. And substance use disorder, and I'm pretty sure I can't cover this topic in this lecture, and this is a vast area. And just to touch, and it's characterized by a cluster of cognitive, behavioral, and psychological symptoms, indicating that the individual continue to use substance despite substance-related problems. And there are different categories, and from harmful use to dependence. Right. I'm not going to talk about harmful use, and I'm concentrating more on the dependence criteria, and where we need to have two of these criteria for the 12 months. And if it is if the patient is having these symptoms every day, like for 3 months even, we can diagnose the dependence. That is first one is the impaired control over the substance use, and they find it difficult to control the onset of substance and when to drink like or to use the substance and the frequency and intensity to what extent they're going to, how much they're using, and the duration, and then when to stop or control. They find it difficult to control their substance use. That's the first criteria. Then increase precedence of substance use over other aspect of their life. And their life is revolving around substance, and they're thinking from the very morning, and they earn for substance, and they are planning for substance and when to take, and that's their life is revolving. They don't have any other source of any other sort of any pleasurable activities. Their main pleasure comes from substance. And the third one, they have physiological features like physical symptoms of neuroadaptation to the substance. They can have tolerance and withdrawal symptoms. Gradually, they need to increase the dose of the substance to get the same effect over the time. That is called tolerance, and when abrupt cessation of substance leading to discontinuation or withdrawal symptom, that is called withdrawal. Well, how are we going to manage? We go to burnout, and it's very important to take care, concentrating more on self-care aspect. Encourage regular exercise, adequate sleep, balanced diet, and how many of you doing physical activities? I think per week, most of you do less than 2 days. Am I correct? You don't pay attention on physical activities, physical exercises, and some people does not get adequate sleep, especially people who are reading for exams and medical students, and they do get sleep in the lectures and all, but not in the desired time, isn't it? Right, that is because they don't get enough sleep and enough physical exercise, and they get exhausted, and they find it difficult to concentrate. If they can't concentrate, and then if you lose the track, and it's not going to be interesting, and then they fell asleep. Another thing is important aspect is stress management, and the technique like mindfulness, meditation, relaxation exercise. Very few of you doing that, I know. Other thing is work-life balance, setting boundaries between work and personal life. I used to tell most of my patients, and when they come, especially the staff, and to leave the work when you leave in the gate. Don't take them at home. And with many people, they mixed up work and life. And then they get problems in both places. They get problems in the personal life, and they get problems in the workplace also. It's really important to balance the work and life, and the taking breaks. How many of you taken a break at least 1 week or 2 weeks to repair yourself, repair your mind, and the spending. It's very difficult to take a leave, and because of the situation in the country, and we have to work, and some people have to work after hours, and you find it difficult to take a leave. But it's really important to think that aspect and to take a leave. It's going to shut down vacations and regular breaks. You need to encourage, and some workplaces they do encourage um, taking vacations, and that they overpay the vacation, and that they encourage you to take vacation for 2 weeks at least, and that's improve the performance of the company. Some uh, companies does that. And seeking professional support is very reluctant, especially doctors are very reluctant to seek professional support, and they don't uh, like to talk to counselors. They, as professionals, and we in the medical field, and the doctors and consultants and all are in the sort of in a hierarchy in the top. So we feel that we know everything. So we are reluctant to go and talk to other people. That's not a good thing, because we need to talk, and we need to get support sometimes from counselors. And we present at the last stage when we really find it difficult to cope, as the stories we heard at the very beginning. And they might do harm to themselves, or when they're depressed, really depressed, or they have severe anxiety disorders or alcohol, substance-related problems, only they present. And workplace interventions also important, and uh, implementing changes in the work environment, such as reducing workload if possible, and giving an increase in the support, and then if the management can increase the number of doctors, and if we can cut down the number of patients, sometimes it's very difficult. Well, that at least, and if you, let's say, if 10 people are there, and if they can give two people sort of relief and other contribute. And what happens is, with time, and we don't have this cohesion. Some people used to take excessive benefits, and few people getting exhausted. That we need to look into that, and we have to work cohesively to overcome these problems. It's really important to learn a little bit about time management. I know most of you have sort of mental map about the time, but if you really do sort of time management, and you will realize how important it is, and you can do a lot of stuff by doing a good time management, and the problem solving skills, and help with the reducing work-related stress. Well, depression, in the management of depression, it's slightly different, and we have mild to moderate sort of depression. We can give cognitive behavior therapies and interpersonal therapies would help for the mild to moderate depressions, and the moderate to severe, we need to have pharmacological interventions. Lifestyle changes also very important. Regular exercise, are reiterating on that, and the physical healthy eating, and sufficient sleep, and the supportive networks, and stress reduction, and incorporate relaxation techniques and mindfulness to the patient, and routine establishment of routine is very important. And when they are depressed, and their routine get disrupted really, and then putting them back into the daily routine also important. These are the things we do for the depression. And a little bit about pharmacological treatment, I thought it's important, but I'm not going to go into very much detail. We don't have time. mainstay of treatment for the depression. I think at the GP level, suppose they can start treatment for the depression. We know, I told you about the diagnosis, and all the depression does not need to come to psychiatrist. And they, at the primary care level, and our doctors are very reluctant to start SSRIs. Some people are starting SSRIs more regularly, and but at primary level, moderate depression is better. You can start, if you can start antidepressant. Mainly we are focusing on SSRIs. That's the first line of treatment. Fluoxetine, sertraline, escitalopram, and duloxetine is there. We are using frequently. Under government sector, we have fluoxetine and sertraline. We have citalopram also. Citalopram and escitalopram fairly similar, and we can start that. Out of them, the fluoxetine have good evidence base and the well researched, especially among young adults, and sertraline also. But escitalopram is well tolerated medication. Side effect is concerned mainly the GI side effects. Some people can get lightheadedness, and those are the main side effects, and the sexual side effects we see, and that is mainly reduced sexual desire. But the depression per se can cause libido issues, and they have low libido, and these can cause delayed ejaculation, that sort of side effects. And SNRIs, serotonin noradrenaline reuptake inhibitors, and there we have venlafaxine and duloxetine, and the mechanism is very much similar to SSRIs, but they reduce the reuptake of noradrenaline also. So when we start venlafaxine and duloxetine, and the activity, they get more energetic, and that's the benefit over SSRI. But the tolerability is not so good as SSRIs. Duloxetine we using during the pain. If they have chronic pains, and we can use duloxetine. Venlafaxine, the main problem is they can cause hypertension, and if you're starting venlafaxine, you need to monitor. Let's say your patient is having hypertension, and it's better not to go for venlafaxine. Rather than venlafaxine, you can go for SSRI. If you are starting venlafaxine, it's better to monitor blood pressure. Another risk is then that they might, and then even some people, especially bipolar patients, they can present with depressive episodes, and if we treat with venlafaxine, risk of shifting towards mania is high, about 10%. And tricyclic antidepressant, that's what we frequently say in the medical clinic when I was a trainee. It's about 15. During my post-intern period, about 15 years back. At that time also, we used to give small dose of amitriptyline, and we used to tell then we can give amitriptyline 12.5. Then I realized, and I did that. Still, I see these prescriptions, and you for sleep, you're giving amitriptyline. Amitriptyline is not a good choice, especially in elderly, and it can cause a lot of cardiac. The anesthetic team is there, and it can cause a lot of cardiac arrhythmias like symptoms, and it's not a good medication to start as the first line. And on the other hand, for the depression, we need to have at least 50 to 100 milligrams of amitriptyline, and generally 75 milligrams. But most of our patients, and if you start amitriptyline and then you start 10 or 12.5, in the private sector it's 10, and the government sector half a tablet 12.5, and it's not going to help with the depression. And it's a side, as a side effect, it's over sedating, and then they can get sedation. And it's in a long run, it's not a good choice, I suppose. And it's not going to help for the depression. And if you want to start uh, treatment for depression, and it's better to go for SSRI rather than amitriptyline. And other antidepressants are the bupropion and mirtazapine, and it's not so new, but it's available. And mirtazapine is a good choice for people who have sleep issues and depression. And it helps the both, and it's a main problem with it can cause increased weight gain. Bupropion, it's very good drug, but along for the bupropion alone won't help for, generally doesn't help much for depression, which is most of the time we use to augment. And it's very good for the people who are using nicotine and smokers, and we can use bupropion to help with their nicotine dependence. Right. There's a little bit about the medication at your level. At the medical officers, majority of here are medical officers, that they can manage simple depressions and moderate depressions in their practice, and that they can start medication, and rather than referring or not treating them. And substance use disorders. And this is also mainly, this is a very vast topic, and I'm going to touch a little bit. And mainly the behavioral therapies would help, and especially cognitive behavior therapies, contingency management, and the motivational interview. Motivational interviews have a lot of evidence based, and you can do it. Pharmacotherapy mainly for the withdrawal management. Once the withdrawal is managed, and you can help with craving, and most of the time they have comorbidities. They can have most of the people, they use multiple substances, and they have comorbidities also. Then you can use antidepressant for depressions, anxiety disorders, SSRIs, and likewise. And there are rehabilitation programs, and we have for the alcohol, there are rehabilitation centers are there. We are running clinics for them, and we can help them for the rehabilitation. Then groups are there, but still in Anuradhapur area, there are no, I'm not sure whether they are functioning, but in around Colombo, Alcohol Anonymous groups are there. Narcotic Anonymous also. And it's very important to have a sort of integrated care, and because there are a lot of comorbidities we see among substance users. They might have liver problems, they might have some cardiac problems, right? They have a lot of comorbidities. They have metabolic issues also. And it's a very important part of substance use management is relapse prevention. They need sort of continuous support, at least for 6 to 1 year duration, to help and prevent relapses. Then I thought of summarizing that at different levels, and how we can promote mental health and minimizing the stigma at the individual level. As I told you before, I'm going to rush through this because I don't have enough time. As I told you earlier, this is self-education and the healthy habits. And I told you earlier, counseling, stress management strategies. And for this, it's very important we have to speak out, and when they have mental health issues, and that would help us as well as to the colleagues around us. And when they have a mental health issue, and the next time they would present, rather than staying without getting any support till last stage. And if there's any misconceptions within our community, and this is very important to rectify them. And at the department level, at the team, and there are a lot of things to do. And very important to have a sort of inclusive atmosphere. Then we people are different, and their personalities are different. When we are working in a group, it's very important to understand the differences and we work in cohesively, and that helps us as well as others. And here also the having open dialogues about mental health, that would help in reducing the stigma. I'm going to skip this. And a little bit of some models and problem solving, and that's important part in self-care and mental health self-care. And if there's a problem, and we have to think whether we can change the problem. If we can change, it's the good time. So if it is the good time, we go for problem focus coping, right? If it is not the good time, or if we can't change the situation, and we go for emotional focus. What are they? The problem for focus coping is and the way we actively look into the problem and then find out the solution, try to find out solutions, getting organized, and the time management. Assertive communication. It's really important to have assertive communication when you can't cope with, for instance, let's say if you can't do that work, or if somebody asks to cover on call, right? But you have set of things planned for that on that leave, so you can't do it. And but rather than accepting it, you have to be assertive and you have to tell it in a nice way that other party also does not feel embarrassed. And in a nice way, if you tell that you can't, and that's important for problem solving, right? That is assertiveness. You have to develop your assertiveness and other support. And emotional focus is when you can't change the stresses, so you have to cope with it. Then you go for emotional focused coping, and then you have distraction, and you can do pleasurable activities, and you can talk to a friend, and there are breathing exercise, relaxation exercises, and mindfulness, and those helps with emotional focus. And the time management, that's a really important thing, especially for everyone, and especially for PGM trainees, medical students, and the utilize, and you have to prioritize what is important, what is not so important. And then you have to, you can use different methods are there, ABC method of prioritization, and there we think about most important and urgent thing, and we need to do it then and there. Next one is it's more important, but not so urgent. Then they can do later. And urgent, but not important at all, then you don't need to do it. That's urgently. So it's under C. And that's really important too. You have to have a prioritization, your tasks. Then you have to plan and have a schedule. And it's very important to have set of goals in your life. And even for minor things like your studies and all, and you can have a SMART goal, and then specific, measurable, achievable, relevant, and time-bound goals. It's important in time management. And the procrastination, it's need to be avoided. And there's a famous Pomodoro technique, and where there's a clock called Pomodoro clock, and you can set the time 25 minutes and it rings like this. And this is a very evidence-based thing, and you can work for 24 hours, 25 minutes, and you can take 5 minutes break. And you do 4 cycles, and then you are going to take a longer break somewhere around 20 to 30 minutes. Again, back to that routine. And that's how you're doing it. And the 2-minute rule. There are minor things we use to procrastinate. For instance, switching off the light. It doesn't take more than 2 minutes. All the things take less than 2 minutes, and you can do it then and there. That's your rule, and you are going to have that rule. And then let's say you have to watch the cup, and you don't need to procrastinate that, and you can do it then and there. You are doing less than 2 minute stuff. You do. If you're sending an email, maybe 2 minutes, and then you can do it. But you might think, and why should I do that? Because it's small task. When you fulfill this task and your mind feel that I'm doing work, and you get the satisfaction of completion, and that would help in your mental well-being, and then gradually you start not to procrastinate other things also. And the managing distractions is really important. And if there are a lot of things to distract you, for instance, if you're studying and then the phone rings, and then you start taking the phone, and then you see the message, and then you go to the Facebook little bit to scroll down, and then YouTube video, and then coming back, and you leave 30 minutes or 40 minutes, and then you lose a lot of time. And then to minimize the distractions, and you have to have sort of rules in your life and to reduce the distraction. And then you have to delegate yourself for tasks, and self-care, work-life balance again comes and it's really important. And the last bit, and how would have saved Dr. X in the early academic career, and if he lucky enough to get the emotional support that he needed, and he would have been saved, and he would have developed enough coping skills in the early career. After that, they had marital conflicts, family conflicts, and the marital and family counseling would have helped them, and they would have sort out their conflicts and would have saved. And financial education and the counseling. That's very poor, that most of the doctors, and they are very poor in managing finances, and they get all the credit cards and all, and the bankers, the bank people, they come in behind, and then they wanted to spend. And they spend, and because other thing is they in a community, and they are in a sort of a different position, and they can't be without paying also, and they can't say no, and they spend a lot, and they go into financial crisis, and most of the doctors have taken loans, and they don't get hardly enough to take on. That's another thing, and that's what we saw during the crisis, and just after crisis, everything went up, and the doctors was quite struggling. That's financial education is also very important, and we're getting enough. If you are not very much good at that, and he would have get some financial advices. Substance use, and it would have prevented, and by prevention strategies and intervention we would have done for substance use. Anger management, and that's also we could have dealt with. And the workplace support. If he had colleagues to have at the workplace and direct to proper care, maybe support and social support, sometimes medication would have helped him and would have saved him. That was the unfortunate event of Dr. X. And there are so many Dr. X's around among us, and we need to help them. And if we can understand that, at least I feel I achieved my objective. Thank you very much.